Dr. Ramesh, good evening.
Hi,
Shall we start?
Nihaal. Good evening. Yeah, sure.
I think the fellows haven't joined yet, but yeah. Okay. So once again, thanks everyone for joining in. I think we have a good set of cases this time, pretty complex set of cases. The chat is open. Please feel free to raise your hand or put in your comments in the chat box. So without further ado, I'll hand it over to the team at Rainbow. If we need Dr. Ramesh, yeah, can take over.
Good evening, everyone. Good evening, sir.
Yeah.
We did discuss this case a couple of weeks back. So just to quickly brush up on the history, what happened after the last meet. So this was a 6-year-old child who was diagnosed with B-cell ALL in Jan 2025. He was given induction and then BFM protocol as well. And he was first brought to us on May 23rd with first episode of focal status epilepticus. We proceeded with imaging during this first admission.
Yeah, so first admission, I mean, as previously discussed, there are few focal areas of edematous changes, predominantly in the cortical, subcortical regions of the temporal and parietal lobes on the left side. Yeah, so these were the, I think, main findings, and yeah, nothing on the SWA to suggest hemorrhage, nothing on the contrast. At that time, we thought of possibilities of treatment-related changes or press or remote infective etiology, and the child was evaluated accordingly.
So not much of etiological clues. We decided to proceed with CSF analysis with culture along with PCR and malignant cells, which all turned out to be negative. He was extubated on the same day and he was discharged 6 days later without any neurological deficits. And in May last week, he was admitted again under hemato-oncology team with complaints of some non-specific febrile illness which lasted for around 5 days. So he was admitted basically to give antibiotics. So fever spikes, frequency and intensity reduced with just antibiotics and symptomatic management. And day 3 of this particular admission, we had reviewed as well. Neurological examination was normal. And day 5 of admission, when the child was planned for discharge, on the day the child had sudden onset right-sided weakness with encephalopathy as well. He was disoriented, not recognizing parents, and inconsistent following of commands as well. On this particular day, on the acute event, GCS was around 12 with right hemiplegia without any cranial nerve involvement. This was on the day of the acute event.
घबराने की बात नहीं है, लेकिन ये प्रॉब्लम है कि
Didn't
उसका ऑपरेशन करने में भी दिक्कत होने वाली है, क्योंकि हाथ
Dr.
मतलब
Rani,
आगे नहीं है।
Dr. Rani, can you mute
में
yourself,
दिक्कत
please?
होती है। अभी ये दवाई चालू करेगी, उससे एक दवाई है वो ट्राई करेंगे।
Sorry, yeah, go ahead.
Yeah. We did an imaging on the same day as this acute event.
Yeah, on the follow-up imaging, there was some progressive new changes, especially in the thalamus out there. Some white matter changes were seen, and hippocampus on the left side. Mild distributed diffusion. Some areas of linear distributed diffusion in the hippocampus. We attributed this possibly to related to the seizures. And again, similar differentials were thought of, this time more of inflammatory, demyelinating, infective causes. And I think child was similarly evaluated. Contrast did not demonstrate any enhancement again on the follow-up scan, and no hemorrhages were seen at this point of time. Again, the differential was the same as the first scan, but yeah, progressive changes in terms of the left thalamic and hippocampal involvement. The right way, the cerebellum was there in the first scan also, but yeah, slightly more prominent now. So yeah,
Right.
differentials thought of was these, and I think we kind of thought of these and as child was evaluated.
Right. So with this particularly imaging background, definitely got us rethinking our differentials. And since we could not establish any infective cause and unlikely to be related to treatment as well, our primary differential was definitely demyelinating. So keeping this as our primary differential, so these were the issues during the course in the past 2 weeks. So sensorium, there was progressive decline over 3 days after the acute event to the present state, wherein the child is completely comatose. There is no motor response, no autonomic reactivity. Brainstem responses partially preserved in the form of pupillary reflex and spontaneous shallow breathing and worsening DOLSA as well. And the issue of being persistently comatose was definitely challenging for us because despite aggressive immunomodulation, he never responded. And the seizure burden onset of seizures again one day after the acute event was there, which eventually evolved into high seizure burden, drug refractory as well, requiring infusions of both midazolam and ketamine, which recurred on tapering. And however, we were able to stop both the infusions completely by 8 days after the onset of seizures. The child is presently on keto diet. So in the past 6 days, the child has not had any electrographic or clinical seizures. And Optal as well, initial on day two of the after the acute event, bilateral VP were absent. Grade 2 RAPD was there initially, which gradually worsened to asymmetric pupils. Presently, right eye is mid-dilated with very sluggishly reactive left eye. There is sustained hippus lasting for up to 1 to 1.5 minutes and poor Dolce as well. Along with this, there were systemic issues as well, continuing fever spikes lasting for almost 6 to 8 hours, somewhere in the range of 100 to 101.5 degree Fahrenheit, without any localizing features. We had repeated septic markers multiple times. CSF analysis was also repeated, along with NGS as well, which turned out to be negative. It was presumed to be central in origin. So the present issues are definitely with the sensorium. The child never had an improving trend of sensorium with such aggressive immunomodulation which we had given. And as we can see, autoimmune workup as well. Autoimmune encephalitis panel and serum NMO-MOG also turned out to be negative. And malignant cells which we had repeated with adequate quantity of CSF also turned out to be negative twice. And interleukin 6 was around 10.9, and ferritin was in the increasing trend, 197, later jumping to 1690. This was 4 days back, for which anakinra was also advised by the hematonco team, and it was started as well.
All right. With that, I think we have two sets of scans. I think 10th and 18th. So on the 10th scan, similar to what we've seen on the previous study, and again, you can appreciate predominantly left-sided abnormalities, thalamic abnormalities, cortical, subcortical abnormalities in the lactate, in the parietal and temporal lobes, and these patchy white matter changes, which we have seen in the previous study. Diffusion, again, you have these hippocampal changes, which are already seen on the prior study. So on a 10 scan, in terms of imaging evolution, not much. In terms of contrast enhancement, again, there was no enhancement of contrast, no leptomeningeal enhancement, no cranial nerve enhancement, given that the child had a background of leukemia. And spinal cord also did not demonstrate any myelopathy or lesions. And this was the scan done yesterday. And on this scan now, you can appreciate that there are new abnormalities, especially in the left basal ganglia out there. You can see that there is new areas of restricted diffusion. The left parietal and periloandic region also demonstrate slightly more conspicuous now than the previous study. The contralateral side also has some areas of restricted diffusion. Coming down also in the thalamus, I think better appreciated on the flares. The contralateral and thalamus also now demonstrates some slight degree of diffusion changes. And now the brainstem also has these patchy abnormalities which were not seen on the initial scans. And again, this inferior cerebral hemisphere, this focal abnormality, again, which was not seen on the previous scan. So these are the new findings which we've seen on the latest scan, that is the left basal ganglia abnormalities, the contralateral parietal lobes, the thalamic abnormalities, and the posterior fossa abnormalities. Yeah, so the extent of the lesions are better appreciated again on the flares. So you can appreciate, yeah, so these parietal lobe abnormalities, more on the left side. The white matter changes have slightly progressed in comparison to the prior study, and you have these deep brain nuclear changes, especially on the left side, basal ganglia thalamus, as progressed in terms of lesion comparison. Also, the optic tracts now and the anterior commissures demonstrated these areas of T2 flare appendices, which are not seen on the previous study. And you can appreciate the brainstem signal abnormalities and the cerebellar abnormalities. Again, progression in terms from the most recent study done a week prior. Again, there was no hemorrhagic foci. Initially, we did only a plain scan. And in the plain study, some of the areas of abnormalities in the deep brain nuclear structures, especially the first two foci, you have significantly elevated choline peaks out there, reduced NA peak, and you have a lactate peak demonstrated on both sides. This is slightly relatively normal brain parenchyma, and you can appreciate the difference in the spectroscopic signature. Then the child, we thought maybe it's to evaluate for any enhancement in contrast. So contrast was given, and contrast again did not demonstrate any enhancement again. No intracranial enhancement. There was some swelling in the neck that was also assessed, and you can appreciate there's generalized edematous changes slightly more on the right side of the neck, posterior aspect. Some collections out there, but nothing in terms of abscess formation or lesions out there in the neck. So these are all intramuscular and subcutaneous edematous changes, diffuse edematous changes, or inflammatory changes in the neck region. No cervical lymphadenopathy was seen. and no bony abnormalities or cord abnormalities on the spinal cord. Just to give you the brief idea of the presentation of the child in terms of imaging, this was the first scan, all of flare sequences, non-contrast. So patchy abnormality is predominantly left hemispheric. Coming down to 3rd June, you have some additional areas of involvement in the thalamus and also the hippocampus, whereas the most latest scan, you have again progression in terms comparison to the first scan, significant progression, especially in the central structures of the suprainfantile brain. With this, I think the main questions.
In 10th,
sorry.
10th scan, there was significant resolution in between 3rd and 18th. Then there is worsening.
Yeah, there's worsening. Yeah.
10th,
I think
there was resolution. Yeah.
So this is the 10th scan.
Correct.
And this is the 3rd scan.
Right.
I wouldn't say significant, but yeah, thalamic change is still there, Dr. Ramesh.
But it was better, isn't it? The
it was
edema
better,
has
yeah,
come
slightly
down.
better. Yeah.
Correct.
I think that is maybe child was, I think, initiated on steroids and immunotherapy, if I'm not mistaken.
Correct.
Yeah, then though child was still on the same medication, but still now the child is now the lesions have increased and new lesions have formed. The question here we are thinking of is it still an infective process? Though all the labs have come out to be negative, there are some papers out there which have initially found out to have negative PCRs and imaging patterns somewhat similar to what we have seen in our cases. This is a review from the Tata Memorial Group. They had found HSV encephalitis in all these cases. So initial images had patchy involvement, whereas in progression over a 2 to 3 week period of time, you can appreciate the progression of lesions. Few of them demonstrated negative PCRs at the initial time of the presentation. Other possibilities, I think, given the hematology was raised, was can it possibly HLH? In terms of the lesion involvement, possible, but there were some atypical features which are not seen on our scan. There was no contrast enhancement, which is usually seen in HLH. Hemorrhages also can help in identify or support the diagnosis of HLH, which are also not seen in our case. None of the scans had hemorrhages. None of the scans had contrast enhancement. So maybe in terms of the pattern of distribution, yes, but other features were slightly atypical. And then we finally thought, are we dealing with an early possibility of a diffuse or multifocal neoplastic lesion such as a lymphoma or a glioma? These were examples. I think one of our cases we just discussed. Initially, we thought of an infective process given that the diffusion pattern, multifocal appearance, but over a period of time, there was lesion evolution, and the child eventually got a biopsy, and this was turned out to be a high-grade glial neoplasm. So these were the thoughts we thought of as differentials, and we'd like to open the case for any other comments or possibilities.
So despite improvement in seizure control, despite taking of anesthetics, benzodiazepines, barbiturates, spontaneous breathing drive is canvas some resolution. So looking at malignancy seems to be a strong positive with all the motivation given already. Anybody?
What is interesting is that the whole thing is much more on the left side as compared to the right.
Yeah.
And question was the first one I saw, you had hippocampal swelling and you had pulvinar changes.
Yep.
I was wondering if it was because of status itself. Then of course, later on the changes have become more widespread.
Yep.
And I agree that we should rule out an infective process because in any malignancy, I mean, there's either demyelination primarily is a very unusual kind of problem. It would be more likely to be either some leukemic infiltration, but the enhancement is not nodular or anything of that sort. So unlikely, and CSF is negative, or infective. And infective, I mean, you get all weak bugs in immunosuppression. So I think a biopsy would be definitely
So 3 CSFs were actually normal. We did even NGS for viral, bacterial, fungal. Yes.
Sometimes you may get it with that metagenomics or something of that sort. I don't know.
Yes, sir. We did metagenomics only. NGS for microbial pathogens. That's all negative. Pathogens, fungal, bacterial, everything. So Apurva is asking any slow viral infection, is it possible?
Possible
Or slow
imaging wise, but
paralysis.
wouldn't it respond to any kind of uh, the medications which are given? Was the only thing.
Anybody has any experience with the slow viral infections?
Yeah, one of our patients who had this kind of thing turned out to have PML.
Okay.
I remember I had showed it over here also.
Yeah, though predominantly white matter changes, if I'm not mistaken.
Yeah, but that
Yeah.
patient also had basal ganglia, if I
Yeah.
remember right, white matter and brainstem changes.
Yeah.
And have you done the CSF or JC and all those viruses? BK or JC or whatever those other viruses are.
This metagenomic NGS, I think it covers all the known viral pathogens. We didn't look at the individual list, but they have close to, I think, in thousands,
Would
the
be.
number of, yes.
Yeah.
Biopsy should.
I think biopsy would be indicated, don't you think? Because you don't have a answer and she's just going down.
Sure. Thank
The
you.
only thing is the site of biopsy, Dr. Ramesh. Maybe I thought the deep ones are most prominent, but is it?
Okay, so Anas is asking which sites are
that's
appropriate or likely to have better yield.
The central ones are better, more involved, but with how risky is it, or what are the side pros and cons?
I think our surgeon and we were discussing because most consistent and dense lesions are there in the thalamus from the beginning. So left thalamus, putamen are close proximity, and Dr. Lokesh suggested posterior temporal, left posterior temporal. So maybe if we go for biopsy, those three areas we would probably plan to sample.
Yeah, I think we need to hit this central areas. Yeah, additional these things are peripheral ones are fine, but yeah, central, it is more predominantly in the central regions.
Apart from that, is it justified to repeat infectious panel again, PCR or an NGS? It's been almost 2 weeks since acute event. Still,
I don't think so, because he was for ongoing fevers. He has been on all possible antibiotics, isn't it? Gram negative, gram positive, antifungal, everything he has been on for possible systemic sepsis.
Right. So, as Nihaal sir had told, there was a few case reports wherein the viral PCR turned out to be positive almost 2 weeks after the acute event in the evolving phase.
Yeah, these were cases of HSV, of cases of some degree of cancers from Tata. So few cases, I think after 2 weeks, they came out to be positive for HSV. Whether that applies to all the viral organisms or not, before biopsy, maybe what is.
Okay. You mean one more CSF for herpes?
Yes. Yeah.
Okay.
These were all herpes. I mean, some of them are showing similar to what we have seen, peripheral involvement and deep brain nuclear involvement, and they found it slightly atypical to what we commonly see in herpes because lack of enhancement, lack of hemorrhages is what they found in immunocompromised patients. So what
but are
typically,
these were they negative initially and then
they were negative. They were negative
later?
Yeah, negative initially. I think 4 out of 15 cases came out to be negative. After 2 weeks, all of them came out to be positive.
Okay,
So
sure. We'll keep that in mind, definitely. If we are repeating CSF, definitely we'll do that. In the meantime, we'll probably add acyclovir then.
Yeah.
Thank you.
Okay, Dr. Anish asked, HLH possible. Anish, imaging wise, some typical ones are not seen to be confidently determined as HLH. If there was some punctate or nodal enhancement, that would have been helpful, or hemorrhage. But yeah, lab wise, I think ferritins were increased. TGs, I don't think much, but yeah, ferritins were definitely increased. MRS of cortical lesions was not done. Dr. Saujanya, only the deep brain nucleus lesions were done. PML, yeah, Dr. Taj says. Yeah, GM involvement, as Dr. Udani has already mentioned. Yeah, predominantly white matter, but we have discussed cases with few of them demonstrating gray matter involvement. I'll share the paper from Tata on the WhatsApp group. So yeah, I think we'll to conclude, we'll probably possible get a repeat CSF and then look for biopsy of these lesions.
Yeah, sure.
Yeah.
Thank you.
Okay.
So,
Right.
This was a neurosurgical case. 8-month-old child was brought with complaints of increasing head size and vomiting. This was somewhere in April. No other significant history. And MRI brain, which was done on OP basis in April, this was.
All right. So increased head circumference, the indication was looking for any SOL or any space occupying lesions. And you can appreciate there is a large posterior fossa arachnoid cyst following CSF intensity. I did not put in the other sequences, but yeah, it was clear on all the sequences. Predominantly right-sided and crossing the midline, causing significant mass effect on the dorsal aspect of the brainstem and the cerebellum, resulting in significant supratentorial hydrocephalus. You can appreciate the interstitial edema out there and significant dilatation of the supratentorial lateral and third ventricles. Contrast, there was no enhancement. They were feature of raised ICP, as you can see out here on the SAG image. Lowering of the fourth or third ventricle, compression of the cella, papilla edema also there. So I think the child was again referred for neurosurgically and surgery for possibly shunting or decompression. Yeah, I think the child went on a shunt.
This child was operated at a different branch. So the child underwent incision of VP shunt as well as cystoperitoneal shunt as well in the posterior fossa cyst, which was just shown. And the VP shunt pressure initially it was at around 130 mm. So then on follow-up.
So I was done a month later. Yeah, on follow-up, you can appreciate that the ventricles have decompressed. There is development of subdural collections on both sides. The cyst is slightly reduced in size in comparison to the first initial study. I think the question here was, what is the possible mechanism? So we thought of possible mechanism of shunt over drainage, resulting in subdural hygromas or collections. This is likely causing a rapid intracranial pressure reduction, and also there's slower expansion of the brain because of the long-standing hydrocephalus, and this development of subdural collections. So these were possibly thought of the mechanisms of the interval changes.
So with this development of the subdural collection, VP shunt pressure was later changed, increased from 130 mm to 150 mm. And 10 days later, this was almost 40 days after the surgery, the child was again brought with complaints of suggestive raised ICP in the form of almost 20 episodes of vomiting and with dullness. And this was the presentation to our hospital, and we did a CT during this time.
All right, so CT 10 days later after the MRI. Now you can appreciate in terms of the ventricle size, it's slightly increased. And what we have seen in the MRI. Now the left hem is the subdural collection is reduced in comparison to the previous scan. There is the increase in the right subdural collection. In terms of the cyst, you can again appreciate that the cyst has now increased in comparison to the prior MRI. So interval changes, midline shift, subpancreal herniation, possibly again causing descending transverse herniation out there because of the compression by the subdural collection. Reduction in the left-sided collection, interval increase in the ventricle size, interval increase in the posterior fossa cyst size. So yeah, possibilities we thought was for these imaging findings is the CSF diversion possibly decreased. This causing the ventricles to be CSF to be increased. Posterior fossa also cyst also has been increased. With this resulting ICP has increased and the left subdural collection it was partially collapsed, whereas the right collection is persisted and enlarged. This we thought was possibly resulting in the raised ICP features and the clinical manifestations of encephalopathy and multiple vomiting episodes. After
So
that, yeah.
with this picture, we did do an tapping of the subdural empyema to relieve the pressure, and the child later underwent craniotomy, evacuation of the subdural collection as well. But we were still unsure regarding the CSF dynamics. So, and after this drainage, there was significant improvement in the sensorium. The child was shifted back to ward as well. And post-op day 4, the drain had almost reduced to less than 20 ml. And the question here is definitely considering the anatomical difficulties here with increasing posterior fossa cyst size and increasing subdural collection as well. So what was the further neurological line of management if there is going to be any? So And what are the indicators of shunt functioning apart from symptoms and signs?
So I think
Which
the main
might have
question
been.
radiologically was, role of CSF flow. CSF flow, I think, will predominantly give us an idea of the flow of CSF from the ventricles to the cyst. If you want to see any communication out there, but I'm not aware if the shunt function can be assessed via CSF flow. If anyone has any experience of that, and indicators of shunt functioning, I think most can be assessed neurologically, and also interval scans to look at the size of the ventricles and the size of the cysts, and also the collections if they're increasing or decreasing. The conventional sequencing may be helpful initially, then maybe you can think of other advanced ones like CSF flow studies. But to assess the functioning of the cyst, the shunt, I think maybe slightly limited role.
Right, sir. So we wanted to know the main cause for the increase in the posterior fossa size. So whether we have to do a shunt revision in the CP shunt, or should we put a subdural shunt, because since it is increasing in size. These were the two options available. Obviously, our opinion was to revise the CP shunt since the posterior fossa cyst was increasing in size.
Do we have a follow-up scan after the craniotomy?
No, sir. That was the last one.
Okay. I think maybe we'll have to see the status of these the collections and the cysts and the ventricles after the operation.
Just a question: is the cyst, posterior fossa cyst, it's separate from the ventricles, right?
It appears to be communicating with the fourth one.
The first one, I think, sir, is the Trudan is asking about the first pre-intervention scan.
Yeah, I mean, so I cannot differentiate the fourth ventricle from the cyst here.
Well, that I understand. Is it that like Andy Walker kind of thing where you have two separate ventricles are separate and the cyst is separate, and you got to shunt both? That's the problem. You don't use a Y shunt because then you might problem. Otherwise, you got to shunt both.
So would it have been better if just the posterior fossa cyst is addressed in the beginning?
Yeah, I think only one would have been better rather than going
I think the problem
two
is the posterior fossa cyst connected with the, is it communicating with the ventricles? The answer is probably not, because after you shunted the ventricles, the cyst has remained more or less the same, right?
On the follow-up MRI, the cyst is reduced, Rakhmani.
But not
if you're draining from both sides, like you are draining the cyst, you are draining the
ventricles, then there's over-drainage.
Yeah, I'm just thinking aloud whether just addressing the cyst in the beginning and then allowing some time for the dynamics to change, and
because the interval scans are definitely showing. Interval scan is definitely showing change of over-drainage. So I think maybe
this is a more of a surgical question, not a
objective. The posterior fossa cyst is not showing over-drainage. It's only the supratentorial compartment. So even if the communication is there, it's not complete. That's what I'm saying. So you may have a situation where one pressure goes down, the other one goes up. You know, that's what I mean.
Yeah.
One of our patients was Dandy Walker. I remember, of course, this time you're saying it's not Dandy Walker, but one of the patients we actually had did a ventricular endoscopy, and we actually did a communication between the cyst and the supratentorial ventricles, and then a shunt worked beautifully. Only one single shunt. Okay.
And regarding the functioning of the shunt, recently we reviewed an article as well regarding usage of USG in shunt functioning, especially the programmable ones. Placing an USG probe across a valve which is present with certain indices, they found to have good sensitivity. Any centers having experience with role of USG in evaluating the shunt functioning?
I guess not.
Right.
What? I'm sorry, I missed the question.
Sir, we recently had an article, sir, where when we reviewed the usage of USG for shunt functioning, they placed the probe over the programmable VP shunt device across the valve to see the flow, how it was. They documented baseline. And on follow-ups, when they documented the subsequent values of the particular indices, they were able to evaluate the shunt functioning before the clinical symptoms could appear.
That's interesting. Yeah, okay. You start doing that then. Okay.
Okay.
Yeah, thank you. I think it is more of a surgical question.
Yeah.
I think we can move on. Thank you.
Okay.
We had another interesting case just last week. This was an antenatally detected asymmetrical ventricular movement with intraventricular hemorrhage as well. We had discussed such cases previously as well. So after birth, the head circumference was monitored daily. There was head circumference was more than 97 centile. Day 1 to day 7, no significant increase in the head size, but it had increased by 0.5 centimeter. This was not per day. Sorry for that. This was increased by 0.5 centimeters over a span of 3 days. There was no clinical symptoms as such. And the examination, apart from the macrocephaly, was normal. It was referred to our neurosurgery department for further management.
Okay, let's have a look at the fetal scans first. So this is at 30-week gestation. I only have these two panels out here, and you can appreciate significant ventriculomegaly, slightly asymmetrical. One side is slightly more dilated than the other side. There you can appreciate intraventricular hemorrhagic changes, more on the what appears to be on the left side here, and also some periventricular abnormalities, especially plastic abnormalities in the frontal lobes, more on the left side again over here. In terms of the on the SAT sequences, the fourth ventricle appears to be normal. Posterior fossa structures appear to be normal, but yeah, predominantly it is the supratentorial region, supratentorial hydrocephalus with intraventricular hemorrhage and periventricular or parenchymal changes. What appears to be on the left side, more on the left side over here. Yeah, I think these are the main findings. In terms of malformation, not able to appreciate any cortical malformations here. These are all glavitic or plastic changes which are seen on the left frontal lobe. I don't have any other sequences, and this was the postnatal scan, I think in the neonatal period. Again, you can appreciate the ventriculomegaly, asymmetrical ventriculomegaly with the intraventricular hemorrhagic changes. And again, these cystic changes in the frontal lobe and the basal ganglia. Yeah, again, on the T1 Medis sequences, you can appreciate hemorrhagic changes, again, predominantly on the right atrial ventricle. Dilatation of the ventricle, you have some parenchymal abnormalities, chronic parenchymal abnormalities with hemorrhagic changes out there. And yeah, on the SWR GRE sequence, you can appreciate the hemostatic staining. And post-contrast SAD sequences, there was some ventriculitis. You can appreciate over here maybe some mild degree of ependymal enhancement. The aqueduct appears to be obstructed, likely post-hemorrhagic or post-infective complication out there. Fourth ventricle again is not dilated. Yeah, with that, I think the surgical procedure was, yeah.
Yes. So with the ependymal enhancement, is it possible radiologically to differentiate whether it is due to hemorrhage or due to infection? Obviously, the ependymal enhancement, I think it was significant on both the ventricles.
Yeah, on the T1s non-contrast and the T1s post-contrast, if you see hemorrhage on has a higher signal on T1 and it's demonstrating the same signal on the T1 contrast, yeah, then you can see it's likely due to hemorrhage. And also the SWR sequence or GRE sequence will help to correspond the blooming foci on along the ependymal margins.
Right.
But this child definitely had enhancement, so there were some postnatal infective changes associated with it, causing hydrocephalus.
Right, sir. So this child underwent on day 15 of life endoscopic lavage with Omaha reservoir placement and intraventricular CSF analysis protein 219, which was probably expected for the hemorrhage, but sugar was around 20, so for which culture was sent and it grew enterococcus. What was surprising and what we didn't expect was a lumbar CSF analysis, which was suggestive of meningitis. So now the child is being treated for meningitis as well. And for the antenatal IVH part, the child underwent evaluation for fetal thrombophilia and genetic evaluation is planned as well.
Yeah, so antenatally, it's difficult to comment if the child had infection or not, but definitely hemorrhagic changes antenatally, the hydrocephalus or ventriculomegaly and the parenchymal changes, one would need to rule out infections and also genetic abnormalities, as you have pointed out. So these are few of the genetic disorders, especially collagen-related disorders to be evaluated and coagulopathy-related disorders. Yeah, if infection is ruled out and you have you have the other factors which can cause intracranial antenatal hemorrhagic changes, especially in the interventricular regions. So the questions here, yeah. Experiences with fetal IVH, indication for lumbar puncture for infantile hydrocephalus. So on imaging, these are the few points I thought of which indicate the evaluation of an LP or to evaluate for meningitis, hydrocephalus, ventriculomegaly, any septations or debris within the ventricles, any loculations, and also post-IVH hydrocephalus to be evaluated by lumbar puncture. And recommendation for evaluation in terms of beneath.
For the IVH only, sir, right? Fetal IVH, anything apart from this?
I think our experience is, even though the hydrocephalus looks like post-hemorrhagic hydrocephalus, we had bad experience of finding out the infected CSF. So either in lumbar CSF or ventricular CSF. So I think based on at least 4 cases in the last 1 year, we should do lumbar puncture also before we go for shunt or any definitive procedure, both ventricular CSF as well as lumbar CSF in all these infantile hydrocephalus. Anybody else has similar experience?
Actually, I have the experience exactly opposite to what you are saying. Can you go back to the CSF results? See, I don't know, but this is a radiology meeting, but I'll still go through it. So there are no cells in the ventricular CSF. So there's no ventriculitis in CSF. That's very clear. We often see that there is hemorrhage. You have contrast enhancement on T1, which is all hemorrhage. And you get this high protein and low sugar because of obstruction. The clue is the no cells. There is no ventriculitis. The CSF is possibly a contamination. The lumbar puncture, often we don't count the RBCs. So here it is written 80% neutrophil. Often there are plenty of RBCs which are not counted, and the result is given as neutral.
No, Vivek, this doesn't have RBCs.
You should go back to check, because
usually
it is not matching. You have no cells in ventricular CSF.
Ventricular I agree, but lumbar, whenever
there is no ventriculitis.
No, correct, there is no ventriculitis. But whenever there is a hemorrhagic setting, we always insist that please tell number of RBCs also to see whether they are proportionate. That ratio, that we always look at. Definitely. Just high protein and low sugar, we don't always say it is infection.
Because n number of times we have, and we have not treated. And the children have just come out because we have been over treating for ventriculitis for children with hemorrhages. And they,
I agree what you are saying, but this is not including RBCs. We did look at the RBCs.
And normally meningitis starts from the choroid plexus as a ventriculitis in newborn. So if you don't have any cells and have so many cells, is very odd. Anyhow, it's just time we should discuss some other time, because more of a radiologist meeting. So but it's actually other way around. My experience mostly it's mostly hemorrhage, which is being mistreated as ventriculitis.
Okay.
Right. I think that's all, sir. Over to you.
Yeah. Okay. No recommendation for evaluation for LP, or is it
IVH, sir? As
IVH, IVH has because antenatally IVH is difficult. We don't have any clear evidence of an infection. Genetic is we wanted. Though infection can cause intracranial hemorrhage, as listed out here.
Right.
Okay. All right, Dr. Vivek, what do you?
Yeah, so it's a set of 5 cases. So this is the one which we have already discussed a year back, and twice we discussed, and thanks to Nihaal, who gave us a gene which we pursued, and we were able to find it at the end. So this baby I had seen for the first time at around 15 months age, and she was a twin delivery. She was a dizygotic twin. And she was the better of the twins, 2.3 kg. The smaller one was 1.2. So birth was fine, no problems. And as she grew, it became very clear that she has significant motor, more than cognitive involvement. She was delayed, but it was more motor, and it was more of a movement disorder in form of truncal and limb dystonia. There was bradykinesia, and there were some hand stereotypies all the time. Her facial expression, you will see in subsequent videos, was slightly less, but she was quite alert and she was very interactive, like in this way, mother. So she has jaw opening dystonia, she has arm dystonia, she does have bradykinesia, and the other videos sort of show the same. So more of a dystonic child. Her reflexes were actually, I was surprised, they were not brisk. They were just elicited. I thought it's more of an extrapyramidal disorder, so that's why they are not that brisk. And it's more in the arms than legs. Legs have more of stereotypies. And the facial expression was less, but she was much better than what she looks here. So cognitively much better. Right. So we have two sets of MRI. First one done at 13 months.
First one was, yeah, 9 months. I think we had discussed this
9
couple
months.
of times. We had similar cases from, I think, Indore. Couple of cases had the similar pattern of involvement of the thalamus. You have this sparing linear areas of sparing out there, and also involvement of the olivary nuclei with progressive hypertrophic olivary degeneration. Some degree of thinning of the corpus callosum and atrophy, but your main changes were in the thalamus and the brainstem, especially the medulla. Spectroscopy did not demonstrate a very mild lactate peak given the abnormalities out there. Other than that, nothing very significant. I think lactate also was normal for this child.
So we did, at this stage, we thought, is it mitochondrial disorder? As we'll always think of such sort of, with the involvement of the thalamus, more of the midbrain, involvement of the medulla. So we did blood lactates, which are normal. We did TMS. So first time they said query MSUD, but second TMS was normal. Urine GCMS had shown ketone, lactate, higher lactate. So we again thought, oh, maybe we are dealing with a mitochondrial disorder, and we have not picked up from the subsequent testings. So we did a whole exome, we did a trio-exome, we did a genome sequencing. Everything was normal. We have done nerve conduction since then. There is evidence of axonal neuropathy in it. So since we ran out of options, then this was over 2 years. These results were coming through, and we repeated our MRI again, right, at 3 years age. And there was cortical atrophy. The rest of the lesions were the same, probably, right? Static.
Yeah, probably same. But yeah, neurodegeneration going on there, and yeah, the almost similar pattern.
And then suddenly one day I receive and there was a spinal cord involvement, right? Spinal cord was also involved.
Yeah, it looks like hyperintensive. We don't have axial sections, but yeah, appears to be slightly thinned out.
And then one day I receive a message from Nihaal and he sends me some photographs. I said, this is my patient. He said, no, this is the patient from Bhopal. And looks similar to yours. And amazing that, Nihaal, you could remember my patient from before. And then he told me, can this be FIC4? Because you have searched for it. So at this stage, MedGenome had started doing mRNA sequencing. So we did a skin biopsy and sent the mRNA sequencing and specifically asked them to look for FIC4. And lo and behold, we got FIC4. And then they went back into the exome and they had missed it. So there was a homozygous mutation. And the thing about, so when you do mRNA, you look for, the result of the exon-intron interaction, but also the function of the mRNA, the protein and everything. And what they found was the protein which FIC4 makes was normal in this child protein, but when they did fibroblast culture, the protein function was abnormal. So it's not as simple as getting FIC4, getting the amount of protein as normal. It was the function which was a problem. So a bit complicated than usual stuff. But yes, this matches the FIC4 which has been reported before, and we did get it in the end. And thanks to Nihaal for helping me out with it.
Yeah, thanks, Dr. Rick, for the follow-up and the confirmation. I think We had a couple of cases also from Ghosh who had similar imaging findings. I think Dr. Vijay had showed me a similar case at the IRI meeting a couple of weeks back. Very similar imaging findings. So the imaging findings appear to be very pathognomic, especially this thalamic involvement with sparing of these some areas of the thalamus out there. So linear area of thalamus over a period of time appears to be hypertrophied. Especially, you can appreciate the olivary nuclei demonstrate these hypertrophic degenerative changes, and also the alumni appear to be slightly swollen here. But this linear lane line, which is sparing it, and these HOD-like changes, along with progressive axonal neuropathy or degeneration causing scoliosis. So these imaging findings appear to be pathognomic, a mimicker for mitochondrial disorders. But yeah, there were some differences from a mitochondrial disorder, especially one we see in Polges. They usually have more posterior dominant involvement and also some cortical involvement along the posterior aspect. This child did not have as more diffuse involvement versus these linear area sparing that was not commonly seen in mitochondrial disorders. So I think, yeah, this imaging finding and the typical clinical phenotype, as Dr. Vivek has mentioned, so that has to be kept in mind of a new, recently described disease of PIC4 related disorder. If anyone has any experience with this, I think Indore has a couple of cases, if I'm not mistaken, because a couple of them were sent for review. If anyone has any experience with that for discussion.
A very nice case. Just wanted to find out, is the clinically, it's a movement disorder which is prominent or the neuropathy?
Yes, sir, it's the movement disorder, which is much more prominent than the cognitive dysfunction.
No, then the neuropathy.
So what did you say? What did you ask?
I'm saying, is a movement disorder more prominent? In this case, it was the neuropathy, because it's been classified under CMT. And the question is it, it looks more like the neuropathy is more subclinical or minimally clinical, while the movement disorder is what you're actually saying.
At least in my case, that was true. That movement disorder was much more prominent.
Other cases also have shown the same thing. This is interesting.
From the reading through, it looks more like the movement disorder, the spasticity, that's much more prominent. I'm surprised they've classified it as CMT4J.
Yeah.
So that's it can even present with amyotrophic lateral sclerosis, ALS.
Yeah. I see.
So it's a form of ALS, maybe. Maybe that motor axonopathy is not a axonopathy. That might be neuronopathy, maybe.
Very interesting. Thanks.
Yeah. Thanks for it. All right. With that, we'll move on to our next case. Yeah, over to you.
So this is there are two children, this female child and her cousin, who I have been seeing both of them. So this child I had saw for the first time at 6 weeks age, and she was having tonic events which are stimulus sensitive, and I thought I've picked up and I've diagnosed hyperplexia because EEG monitoring was not revealing any ictal activity, and we did a 24-hour EEG and we picked up events, and I treated with clonazepam. She also had a left foot syndactyly, which I didn't give much importance because I was so happy that I made the diagnosis. Those events settled, but when I saw her again over the years, she had significant, developmental delay, which was more motor than cognitive. And then she started to again have nighttime tonic events, even on clonazepam, which were not stimulus sensitive. And then I thought, oh my God, I've been counseling them, this thing will go away. And then this new tonic events come, and EEG was abnormal. There were spikes, frontal spikes bilateral, and I gave sodium valproate, and those tonic seizures stopped. So we did 2 sets of MRI. One was at 6 weeks age, and then the one at 2.5 year age when she came with these real tonic seizures. So, and that's her middle images of syndactyly. The first one is when she was smaller, and this is just latest. So she's affected, but maybe at 2.5 year age, she's performing like a 18-month-old child, 18 to 20 months. So not that behind. Okay. And slightly varus deformity of her legs, but nothing much significant, no movement disorder. Her seizures have also stopped, and that hyperplexia sort of events had already stopped within the first few months after clonazepam.
Okay, I think, yeah.
So first set, 6 weeks age, right?
I think I only one set, but yeah, the main findings are these. Yeah, so first set of images, the have T2 axons and the SAT sequence out here. You can appreciate there's dysmorphic basal ganglia out there. The caudate nucleus and the anterior basal ganglia are slightly more bulbous or dysplastic in terms, causing some dysmorphic appearance of the frontal horns of the lateral ventricles. But coming down to the posteriorly, the posterior putamen and the inferior putamen are reduced in terms of volume, and also some cystic changes, which can be perivascular abnormalities, but yeah, slightly more prominent than what we usually see. And you have these linear areas along the podothalamic groove, possible again gliotic changes out here, with some prominence of the adjacent lateral ventricle or the frontal horn. So these are the main changes out here. Maybe I don't have the continuous folded images, but yeah, maybe a foci of heterotopia out here along the right lateral ventricle. There's some thinning of the corpus callosum. The brainstem, especially the midbrain, appears to be slightly elongated. The tectum appears also slightly thickened than what we normally see. And the vermices are definitely hypoplastic with a prominent cisterna magna or posterior fossa CSS space out there. So these are the main findings in terms of on these images. Do not appreciate any cortical malformations in terms of the polymacrogyria or pachygyria or anything like that. So main findings in the basal ganglia. The anterior aspects are slightly bulbous. The posterior aspects are reduced in volume. There's possibly some gliosis out there. Abnormal midbrain and tectal plate, and definitely abnormal hypervermis, demonstrating vermis hyperplasia, and corpus callosum also extend out. That was the first image, and this is, I think, the follow-up set of images. Again,
recent
similar,
ones.
Yeah, recent ones. Again, thin cut sequences, no cortical malformations along the cortex, but yeah, you can appreciate now there are some nodular changes along the posterior aspect of the right lateral ventricle. Again, here a foci out here. And again, the basal ganglia demonstrates similar appearance. You have more bulbous abnormality along the anterior aspect, and posteriorly, again, it's reduced in volume. Some T1 hyperintensity is out there, slightly what we now more than what we see in myelination of the plic. So if you see the myelination over here is slightly more abnormal there. I don't have GRD sequences. Again, the midbrain, look at it's slightly elongated. The midbrain pontine junction, again, this is abnormal in morphology. I have only one SAT sequence. I can appreciate the corpus callosum, but cannot clearly see the brainstem and the cerebellum here.
Is there an ALIC?
Not clearly seen here on the.
Is there a tubular neuropathy?
I think that was the question raised by Dr. Vivek, but I thought this possibly fits more of.
So can I once interrupt? So at 6 weeks age, we specifically sent the exome because I thought it's apoplexia, but then this MRI came through and I thought maybe I'm missing something. So specifically for tubulonopathy, and I've done reanalysis for tubulonopathy again, and it's not there. The exome is normal twice.
Yeah, so what I think we have seen is a set of cases. I think Dr. Ramesh and Dr. Sangeeta also involved. If you look at the brainstem and also the basal ganglia abnormalities, this is a kind of a mimicker for tubulopathy. In tubulopathy, there's usually no gliosis or atrophy of the posterior aspect of the putamen. Whereas over here, you can see there are patchy areas, especially on the inferior aspect. There's reduction in volume, though the basal ganglia are dysmorphic, not what we see commonly in tubulopathies. And also the brainstem and the hindbrain, the diencephalon mesencephalon abnormality, which we've seen, it can be severe and can be milder as might be what we have seen in Dr. Vivek's case. They can also be associated with calcification and white matter abnormalities, along with ocular abnormalities too. So I think maybe to look for, given that the whole exome has come out to be negative for tubulopathies, to look for PCDH12 mutation as one of the possible causes, and other differentials are listed out here. But yeah, I think it would be worthwhile to look for especially PCDH12 for this child. But yeah, the case is open if anyone has any alternate solutions. And also in tubulopathy, just to add, I didn't put up the slide images on the axal sequences. The brainstem is usually there's some asymmetry out there. One side is usually smaller than the other side, which is absent again in this child. This is more elongated appearance of the midbrain, the cerebral peduncles. So giving a degree of diencephalic mesencephalic dysplasia with the basal ganglia changes, some nodular heterotopia out there. So it resembles a tubulopathy, but not entirely on imaging. So I would,
Right. So is it anterior to posterior disruption syndrome or diencephalic mesencephalic junction dysplasia?
Yeah, so, DMJD dysplasia.
And they're mostly genetic or they're mostly not genetic? So
among them, PCDH12 is the most common one to be identified with the gene.
But that would be still rare. Like if you have 100 cases, maybe few will have it, 5, 6. Otherwise, rest is acquired, right? In utero, right?
But the basic ganglia changes, they're kind of a mimicker for tuberculopathy, as you have seen here. We have three cases or 4 cases. I think Dr. Ramesh or Apurva have more clinical details if it matches or not, but yeah.
And they all had PCD, that gene? They all had it, or one like?
No, all had it. All had it.
All had it. Okay.
All right. So this is from one of the cases. One of our cases.
Okay. Yeah. Right. And yes, so as Anas said, this hyperplexia was a very sort of structural variation in the brainstem, which must have caused it. That's the Sure.
Yeah. Okay, so we can ask for reanalysis, Dr. Vivek, and
sure,
and maybe get back to us. Okay.
That was very helpful. And that's our first cousin. Now 2.5-year age, was born nearly at the same time, and he was a good weight baby. He had jaundice, but that didn't cause conductress. He had day 12 focal seizure, and then he is now left with global delay, bilateral sensorineural hearing impairment, moderate, spasticity, some cortical visual impairments, query retinal dystrophy. They're not sure, but retina is involved. His exome sequencing was also normal. And he's much more affected than the other child. That's his first cousin. So the first child's mother and this child's mother are sisters. And here's this. Sorry.
Sorry. Yes. I'll cut.
So the right side picture shows there is a, I wanted to show this like a helicotropic rash on the upper eyelid. There's a redness, which had always been there. Mother always complains about it, which never goes away. It's not that visible probably here, but it is there. And he's much more affected, same age. Yeah.
The only thing is the PIH, was it significant at any neonatal?
He was a good weight baby. So if you have PIH, if you are IGR, that should cause problem. But if you are not IUGR, then like you have not been that affected, at least by the PIH.
Because the imaging is not identical to both. We will get I thought it is more likely an acquired sequelae. You have this periventricular gliosis, scalloping margins, thalamic degeneration, valerian degeneration of the corticospinal tracts. This looks like more of a white matter injury of prematurity than a genetic disorder to me. No calcification or blooming foci on these GRE sequences.
So he was a term baby, and he was good weight. And if you PIH, that comes with the package, and that is what it will be. And day 12 seizure, focal seizure is very odd. Sensorineural hearing impairment is odd for IUGR babies. Retinal changes is odd. More like Aicardi-Goutier type phenotype.
I got the clinical phenotype, but imaging it doesn't match an Aicardi here.
Yeah.
It looks like more of a premature injury, but something happened antenatally or in the third trimester. If you are saying this,
maybe CMV, maybe he had CMV, which was
no, but this imaging is very characteristic of a white matter changes.
Right.
So this typical scalloped appearance, loss of white matter changes, almost eulegeric appearance of the cortex.
Yeah. So the clinical profile doesn't match.
The clinical profile.
And these children are so much better. They are spastic diplegics, but cognitively better. He's the other way around.
Yeah. So imaging, I wouldn't be confident to call it as genetic, but clinical phenotype, as you mentioned.
His exome was normal as well.
Yeah. All right. We look forward to the analysis of the cousin.
Yeah. So this was a child again who, standard 23-month-old baby, term, no neonatal issues, had global delay, small head, and it was more of a prominent diplegic dystonic profile, which was dystonia was again jaw opening, limb dystonia with mild chorea as well. Cognitively, child was stable, but movement disorder was worsening. And maybe we can look at the MRI first and then video. So this is her recent, so she's microcephalic. She has the jaw opening dystonia. She has arms and legs which are dystonic and spastic as well. Legs are. She's hyperreflexes. There are some contractures. So obviously there is some spasticity along with the dystonia. So that's her. We have, this is her MRI, which was done when she was younger. So she's now 30 months age, but this was done around at 8-9 months age, I think, 7-month age. And at that time, the only thing which struck me was the temporal lobes, where I could, so I thought this child had Aicardi syndrome maybe. And I got her eyes checked, which were fine. Hearing was normal. And I couldn't, think of an answer. But the child didn't have any problems at birth. So there is a disorder which we were missing. The only clue was these temporal hyperintensities, and there was nothing else. So then we repeated the MRI. This was the first one, yeah? This was the first one, right? And there were
only
temporal
changes are
cysts
these
as well.
temporal, refractory changes. But other than that, no signal changes.
And child was behaving clinically like a Aicardi-Gouttiere child, microcephalic, dystonic, temporal cyst.
But the other findings were slightly absent. I mean, Aicardi usually has more white matter abnormalities, frontal abnormalities that were not seen. Calcification also, I don't think, was mentioned. Then we had a follow-up scan. I think this is recent.
What happens? So the child has had, in between, child got an exome done. And we won't show this. The gene came, and the gene was homozygous mutation. But somehow it was not at that stage at 9 months matching her profile. And the family is now planning the second child. So then I just few days back did a second MRI. And the second MRI matches with the gene which was identified.
So second MRI, you can appreciate progressive atrophic changes, predominantly in the frontal lobe, temporal lobes. The refractory changes slightly reduced, though some subcortical, these predominantly are perivascular abnormalities now. But now interval changes in the putamen. You have these bilateral, almost symmetrical abnormalities in the putamen out there. Demonstrating mild changes on diffusion various sequences. Spectroscopy, you have this inverted lactate peak out there. And once we have all these findings, we're thinking of a possible mitochondrial disorder causing these abnormalities. Though on the initial scans, it's not very supportive of a possible mitochondrial disorder, but the follow-up scans, given the spectrum of findings, the possibility of mitochondrial disorder to be evaluated in terms of the differentials on imaging.
So 9-month age MRI, first one, 7-month, and now this 2.5 year age.
Nothing else on the GRE sequences. You can appreciate some thinning of the corpus callosum, some hyperplasia of the pons out there. And in terms of, if you look only concentrate on the dorsal striatum, then we're thinking predominantly D, putamenal changes or claustrum, dorsal striatum changes with lactate peaks. Think of mitochondrial disorder. Other differentials on imaging are listed here. In terms of the temporal lobe cysts, as Dr. Vivek has mentioned on the initial scan, an unmarred white matter can appear slightly bright, but this child has slightly expanded gyri, resulting possibly some underlying cystic changes. So, as Dr. Vivek has mentioned, Aicardi-Gouttiere is one of the prime differentials for temporal lobe cysts, but other differentials to be considered are congenital CMV as commonly seen, but other features were absent. Mitochondrial disorders, especially RMND1, are also supposed to have temporal lobe cysts and other differentials as listed out here. So that was the imaging part of it. I think the follow-up scan helps. And then this is the gene which was listed.
So this gene, PNPT1, it prevents small RNAs from coming out of the mitochondria into the cytoplasm. So if it is defective, the small RNAs come into the cytoplasm and they trigger type 1 interferon response. So people are still not clear it is an interferonopathy like AGS or it is a mitochondrial disorder. So there is actually an article, PNPT1, is it a mitochondriopathy or interferonopathy?
I don't have that, but maybe you can share it on WhatsApp.
I sent the photograph. I'll send it
photo,
again.
I didn't have access to it.
Have you done a CT scan? Have you done a CT scan?
No, I haven't done a CT. GRE doesn't show. GRE doesn't show, but CT we can.
I know, but CT sometimes may show very subtle calcification. That may tell you is probably, interferonopathy.
A mitochondrial disorder, which is an interferonopathy. So normally interferonopathy is due to the small RNAs which are not deposited off from the cytoplasm. So interferon response trigger. Here from the mitochondria it comes out. the small RNAs, which triggers the interferon response. Yeah.
Any hearing loss to break? No, I think ophthalmology was normal.
Yeah, normal. And hearing was normal.
And no peripheral neuropathy. Or there?
That, like, clinically, it is not.
Okay.
Yeah.
Yeah.
So maybe in differential of AGS, like if it's not completely matching, and once you find putamen, one can think.
ADAR1 mutations are usually known to affect the basal ganglia putamen. They usually have more of a cystic change over a period of time.
And they come suddenly, isn't it? They have maybe subtle deficits, and we have they suddenly deteriorate, right?
But they
this
usually
child was always
encephalopathy too, I think. If I'm not mistaken.
But it's more acute, subacute to acute, not like a child who's always affected.
Yeah, and calcification again can be a clue. Punctate calcification can be seen in the basal ganglia. So that's a differential to be kept in mind. So a combined possible mitochondrial interferonopathy out here. And the follow-up imaging obviously helps. The initial imaging is pretty non-specific. So again, thanks again for the confirmatory diagnosis. Okay, with that, we'll move on to our next case.
Right. So this is a day 5-old child with an antenatal diagnosis of frontal encephalocele. And when the baby was born, baby was microcephalic and baby was dysmorphic, had a normal homocysteine. I just had this practice of doing homocysteine for all children who have a cortical malformation. So we sort of have been made to realize that sometimes folate and B12 disorders can cause it. So that's why it is written prominently, always normal homocysteine. So this baby has, slightly dysmorphic as a microcephalic child will be. Not much to show on this. It's more the scan.
All right. So neonatal scan, I think first week of life. Let's see if the videos.
He's quite alert, arms slightly flexed, and he has microcephaly and prominent nose. Yeah.
All right. So significant abnormalities in terms of cortical malformation out there. So supradental when you have extensive areas of dysphagia and also polymicrogyria involving the bilateral hemispheres, you have some interhemispheric cysts, especially along the posterior aspect out here. I don't have a SAT sequence to look at the midline structures, but you can appreciate significant cortical malformation supradentally with interhemispheric abnormalities in terms of cystic changes. There is some asymmetry in the cerebellum. The right cerebellum is slightly smaller than the left. On these imaging and diffuse white matter changes, cannot appreciate the deepening nuclear structures, at least on these sequences. You can appreciate the remnants of maybe the inferior basal ganglia here. And only add these size sequences of the on the side sequence. Again, you can appreciate the spolocele. I think MRE was done to rule out for any sutural, any communication with these subplocele or herniation of subplocele, but that wasn't there. So diffuse malformation of the cortex, so with subplocele and macrocephalic child, definitely genetic disorder, but I didn't put in the discussion for this one, sorry. So any genes to be looked at for, it was a question here. I think genetic panel has to be sent for malformations, but if anyone has any...
it's been sent, so I just was hoping somebody can... And there's a question, how did you manage that? So neurosurgeons had apparently operated upon it. So I thought you don't operate that early, but they did. So maybe that's because the blood vessels were not going into it. So just put it back in.
So there's one disorder called affecting CEP genes, Dr. Vivek, that usually has this, they can associate with this ribbon-like abnormalities, especially from the penicillin region going up to the occipital lobes. And they can also be associated with these interhemispheric cysts or arachnoid cysts. That can be one of the considerations. At least imaging-wise, I was thinking that.
Like CEP135. So CEP135 is very... primary microcephaly syndrome is very common cause, and they don't have that bad parenchyma as the microcephaly. So maybe they have. So.
CEP related genes 135, and there's I think a couple of more numericals which can form these.
So it's basically spindle related,
Spindle related,
spindle related disorders, which one has to think. So all those genes I can ask them.
So CP related genes, but they can also be cysts can also be seen. So.
Ciliopathies, right?
Yeah.
Right. Okay. I'll do that. So is the last one. 2.5-year-old boy who had a high bilirubin, again, no bilirubin encephalopathy, easily treated with phototherapy. And then he has had a delayed development, but he's cognitively better. 2.5, more like a 15-month-old child, much more interactive than his motor delay, which is again dystonia with spasticity. A round face, depressed nose, you'll see in the video. His BERA is normal. I was worried if he had the conductress. So BERA is normal, and because if there is BERA is normal, often I just sort of rule it out if MRI doesn't show any changes. This is him. Receding hairline, broad forehead. He's very interactive. He interacts really well, but he is dystonic and hypertelorism, large eyes, small nose, broad nares, long philtrum. But an interactive dystonic child.
Okay. At what age? I'm not talking about.
This was done at 20 months.
Yeah, I think, So on diffusion-based sequences, I'm not able to appreciate maybe some phonical changes, but I think the ADC did not demonstrate any reversal of these signal changes. Coming to the T2-weighted sequences, for almost 2-year child, there's mild prominence of the subarachnoid spaces, maybe some degree of volume changes out there, but more predominantly the frontal lesion. This can also be best. The corpus callosum is definitely thinned for a almost 2-year-old child. In terms of the central structures, I could not appreciate any signal abnormalities of the vesicular ganglia or thalamus. Could not appreciate any volume abnormalities there, and no malformations. In the posterior fossa also, maybe some mild reduction of the midbrain volume, but other than that, nothing significant standouts. The main findings are in the corpus callosum and possibly some degree of cerebral atrophy out there. Nothing picked up on the GRE sequence, and no diagnostic or significant peaks on spectroscopy. So imaging-wise, I would be hard called to put off any particular diagnosis, but definitely supports a genetic disorder given that the corpus callosum thinning is there and some degree of atrophy is there. But in terms of specific condition, I would be hard to point to a particular disorder. But I think your main question was kernicterus. I think kernicterus changes are not there on the MRI, but this gene has picked up. And I checked the imaging.
PIC-B.
PIC-B. Thin corpus callosum, but that is a pretty non-specific finding of thin corpus callosum, which can be seen in many disorders, but supportive of it. Enlarged ventricles, I think that is maybe a secondary to atrophy. I'm not sure the finding of this. Non-specific white matter abnormalities and polymicrogyria. So at least two or three findings are there. Not specific, but supportive of the gene. But if anyone has any other...
Child never had seizures. And alkaline phosphatase is normal because it can be high sometimes in PIC-related disorders, pigopathies, and his face resembles a PIC-B child. So maybe he's a milder variant.
Yeah. And usually they also have some diffusion changes, some central changes in the central structures of the brain. That is not there, but I wouldn't exclude it out completely.
Especially with the history of high bilirubin, you will think of him as a conductress-related child who has his teeth are also affected, but he didn't have any changes, which sometimes happens. You don't get them, but your BERA is abnormal. You have this auditory dyssynchrony where they can hear, but your BERA is flat.
Yeah.
So that's very suggestive of a conductress-related problem. The child hears, but BERA is flat. His thyroid was normal.
Yeah, PIC-B, anyone have seen similar changes? Yeah.
In GRE, do you see changes if you don't see any changes in the globus in conductress?
No GRE.
Conductress? Or do you normally see?
I more rely on the T2s. The inferior and middle aspect of the globus pallidus are usually gliotic or atrophied. GRE, I don't think much conductress.
Right.
So definitely genetic imaging-wise, not specific, but supportive is what I can conclude.
Okay. Because his face resembles a PIC-B child.
Yeah. So part of the spectrum, maybe a milder phenotype.
Okay. Thanks.
Okay. All
I'm
right.
done.
Yeah. Thanks, Vivek. Yeah. From Jaipur, I think we'll move to Pune. Ruchi, if you're there, are you there?
Yes, sir. Good evening, everyone. So, this is a 16-year-old girl who was born out of non-consanguineous marriage with uneventful perinatal period, who presented to us with paroxysmal involuntary movement since 3 years of age. At 6 months of age, she had lower respiratory tract infection with sepsis, requiring ventilatory support for almost 10 to 15 days and hospital stay for almost 1 month. Following the event, she had a neuroregression. She lost her neck holding social smile and she stopped recognizing parents. After this, she had a static course and she started attaining new milestones with delay. Then, by 6 years of age, she was able to stand and walk independently but would fall frequently. Parents had noticed dance like movements in bilateral upper limbs and lower limbs and twisting movements in lower limbs, which were non-progressive, did not show any diurnal variation, not aggravated by any change in posture, and disappeared on sleep. There were occasional sudden jerk-like movements also noted. Currently, she studies in 11th standard with good scholastic performance. And there's a family history of seizure in younger brother and myocardial infarction in father at young age. On examination, her vitals were stable. She was normocephalic. CNS examination shows MMSE of 29/30. She had dysarthria. On motor examination, she had hypotonia and right more than left dynamic ankle contractures. So these were the abnormal movements which were present. As you can see, she had involuntary, rapid, continuous, ill-sustained movements in bilateral lower limbs, and which were asymmetrical, unpatterned, and moderate amplitude, suggestive of chorea, and which increased on questioning her. She was trying to mask her by bringing her hands together and fixing her specs at times. She also had right lower limb twisting movements, which was present distally, suggestive of dystonia. And later she had this intermittent jerk-like movements involving the trunk and bilateral upper limbs as well. And ethetosis was also present. The rest of her examination was normal. On investigations, her lab parameters, CBC, LFTs, and RFTs were normal. Thyroid profile was normal. Ceruloplasmin, homocysteine, ammonia, lactate were also in normal range. Lipid profile was normal. Interictal and video EG were also normal, and there was no ictal correlate.
All right. Imaging at age, okay, recent?
15 years, sir.
All right. So yeah, you can appreciate the main findings here are in the globus pallidus. Symmetrical T2 hyperintensities with reduced volume of the globus pallidus there. In terms of the rest of the basic ganglia, cannot appreciate any significant changes. Thalamus is normal, no diffusion abnormalities. For a 15-year-old, demineralization does not appear to be advanced. Yeah, some very mild degree of reduction of the cerebellar volume. Corpus callosum, again, the posterior aspect of the corpus callosum is reduced in volume with some inferior drooping out there. Yeah, so these are the main findings. I think even the pons, you can appreciate, it's slightly flattened. The belly is not as prominent as what we see. Yeah, so those are the main findings. I think the question here is...
we kept differentials of post-hypoxic changes or any infectious sequelae or Wilson or NBIA spectrum and started her on tetrabenazine. So we wanted to ask the panel if we should consider genetics in this child or should we give a levodopa trial for dystonia as well.
Okay, in terms of post-hypoxic, I know we have discussed changes of globus pallidus, selective involvement of globus pallidus, but common being coming slightly atypical in to not have the other putamen or thalamic abnormalities affected. So I'm not sure if post-hypoxic can contribute to the imaging findings, especially given Yeah, the selective global status changes. And also some degree of, corpusculosum can be reduced because of, post-hypoxic, but there's some degree of gliosis out there in the peritrigonal white matter. But again, Pontine's slightly reduced in volume, selective global status involvement. I'm not sure only hypoxia can cause these changes. Any other comments or possibilities? NBIS, I think Anas listed out. Yeah, I thought of it, but for a 15-year-old, not able to see significant mineralization to call it as NBI, but yeah, I'm not ruling it out.
There was an acute incident initially, right?
Yeah.
Yes, sir. At 6 months of age, she had sepsis and she was ventilated.
I see. But she had regressed after that.
Yeah.
If that story wasn't there, I was thinking we should, with a little bit of loss of cerebellar volume, we should do an AFP as well.
Okay, sir.
Sometimes AT comes with chorea and dystonia without any ataxia. I mean, variant AT, but they don't have this story of going down after some sepsis, or maybe that has connected, not connected.
Yeah. The atrophy usually is slightly more prominent, is what you've seen in 80s, especially the wormis kind of atrophy, but there's definitely some degree of reduction.
No, but dystonic variant may not have much of atrophy. It's the thing.
Yeah.
So it looks very much like a movement disorder of idiopathic. But the only thing over here is, some regression and all that. So you can confirm that story, but do an AFP. It's not a big deal.
Yes, sir.
AFP for genetics, Raghuram? More likely.
Yeah. I mean, just to give you a little more, before you sign up genetics, just do this alpha fetoprotein. If it is abnormal, it will help them to, then you can narrow down the diagnosis to that. Otherwise, you can ask for genetics. What exactly looks like more like an acquired problem. She had some that is negative. She had some problem. Now she's left with this.
So she had these movement disorders which were non-progressive. And also wanted to ask if there is a possibility of post-pump chorea in this patient because caudate is totally preserved.
But post-pump chorea is after cardiac surgery, right? What, she had cardiac surgery?
No, sir, she didn't have, but we don't have.
Usually, if you go through a cooling and the cooling is not uniform, when you do cardioplegia and then the cooling is not uniform, you damage your basal ganglia and you get post-pump chorea. I've seen one case only, because now people are doing beating heart surgery, so it's very unlikely to happen. I haven't heard of it in sepsis.
Any role of levodopa trials?
Generally, levodopa doesn't help in excessive movement. In fact, it may worsen dyskinesias and all that. So if you're saying there's a lot of chorea, then I would be a little hesitant. Tetrabenazine is exactly the opposite. So anyway.
Yeah. So I think to conclude, I think we are moving more towards non-acquired causes. I think genetics, as Dr. Udani has mentioned, AFP followed by genetics.
Yes.
Diagnosis-wise, I think treatment-wise, levodopa, as Dr. Udani has already mentioned.
Yes.
So I think we'll have to send for genetics. In terms of global status involvement, these are differentials, the typical ones which we usually see. NBI is neurotransmitter disorders. Even some AT can also cause these changes. Homocysteine and all was normal, right? No cobalamin related disorders. There's no significant atrophy also of the brains.
Homocysteine was normal, sir.
Okay. I think we'll have to go with genetics for a second.
So the second case is this is a 10-month-old infant who was born out of non-consanguineous marriage and had a normal birth and development history. He had a fall from a cot with face forward, which was followed by nasal bleed, and then he was asymptomatic for almost 12 hours. Following this, he had one episode of vomiting and right focal seizure, which lasted for 30 minutes. After this, they had come to a hospital. On examination, his vitals were normal. He was normocephalic. His GC was 15/15. He was playful and interactive. His motor examination was also normal. So we started levetiracetam for the patient and kept him in ICU for almost 48 hours and then shifted to ward.
Okay, that can you just summarize clinically what we're thinking of at this point?
So this was a case of TBI, traumatic brain injury. He had a fall from cot followed by right focal status, but his examination was normal.
Okay, so CT I think does not demonstrate any significant findings in terms of the trauma. No hemorrhages in terms of parenchymal or extraaxial hemorrhages here. No herniations, no mass effect, no midline shifts. I think MRI will be more revealing. So CT, yeah, unremarkable.
After this, after almost 48 hours of normalcy, he had recurrent right focal seizures, which were associated with electrographic status, lasted for almost 1 hour, and required multiple ASM. EEG done at that time showed a slowing of background with continuous spike in wave discharges over left temporo-occipital contacts with absent sleep architecture. Following this, patient was intubated and he required midazolam and ketamine infusion for his seizure treatment. Investigations were done. His hemogram was normal. CRP was also normal, and LFTs, PTI, and bilirubin were normal. CSF was also done in view of persistent seizures, which was also normal.
Okay. I think a week later after the CT, is that right?
On the third day of fall.
Third day. Okay. Okay. So you can appreciate some changes of restricted diffusion, predominantly in the peripheral regions of the cortex, the bilateral frontal lobes out here, perisylvian regions, the parietal lobe, especially on the left side, and also the occipital lobe on the left side, demonstrates the restricted diffusion. Some mild changes along the basal ganglia, especially the dorsal striatum. You can appreciate the reversal on the ADC sequences. Again, you have subcortical cortical reversal in the affected regions. Also, you look at the deep brain nuclear structures, especially the basal ganglia, they're slightly dark, and also the cortex along the left occipital lobe. Yeah, so these were the main findings on the diffusion ADC sequences. So corresponding changes not as prominent as what we see on the DW ADCs, but yeah, T2 hyperintensities, again, involving the affected areas. You can appreciate the basal ganglia also slightly more hyperintensive, what normally seen, and also the cortex and the subcortical regions are hyperintense. In terms of GRE sequences, no hemorrhages stand out. And midline sequence, midline SAS sequences, the age, sorry, yeah, corpus luteum appears to be thin. I just forgot the age, but yeah, nothing significant here. In terms of vascular imaging, yeah, no significant abnormalities out there.
So, viral panel has come negative. Following these MRI changes, we did ammonia lactate, TMS, GCMS, which was normal. MOG came weak positive, and NMO was negative. We continued the ASM, started pulse steroids, and mitochondrial cocktail for the patient. So the differentials we kept were post-ictal changes or flames or focal cerebritis, but viral panel has come negative now, RCVS and mitochondrial cytopathy. We wanted to ask the panel if what is the possible cause of status in this patient.
Post-traumatic, let's see. Yeah, possible cause of status and further findings.
How old was this patient?
10 months.
Sorry.
It's not. Is there any blood?
No blood.
In the fundus?
Fundus was normal.
There's so much injury, with minor injury having, changes like this. I was thinking of non-accidental. But
no blood, no extracellular corrections. More cortical encephalitis possible, like the weekly. Sorry.
So the CSF proteins were also normal, and he's like 10 months old. So
yeah, it doesn't look like flames or MOG related. I mean, the age, the presentation, yeah, they can have focal seizures, but the MRI doesn't look like the typical flames. Is there any enhancement at all?
I don't have contrast sequences, but
okay.
I don't think they're done. But the viral panel, I think the CSF panel has come out to be negative.
Yeah. And how is the child doing now?
ma'am, currently intubated. We are tapering ASMs. No seizures since last 24 hours.
Mm-hmm. Doesn't look like the typical inflammatory or immune mediated or MOG related.
The cortical variant, Dr. Samantha, the MOG ones? Really the fulminant cortical variants, maybe.
I mean, sure. I mean, MOG is always in the differential, but weak positive. And are these live cell-based assays or these are fixed cell-based assays?
Fixed cell, ma'am.
Sorry?
Everybody does fixed cell.
Okay, because live is more sensitive, so a weak positive on a fixed.
I think only one place in India has started doing live cell, but generally fixed cell. Weak positive anyway can be negative.
Yeah. And there's significant restriction in diffusion. I don't think the typical flames in clinical radiological syndrome will have so much restriction. Do you think this is just related to the status?
No. We have seen few cases of the cortical variant having restricted diffusion, extensive restricted diffusion.
Okay.
The MOG ones, and as early as 6 months of age, having these changes. 6 months of age of the child. So the cortical ones, as per our experience, is the fulminant ones really have restricted diffusion, whereas the typical MOG, the fluffy, those ones really do not have these changes. So
right.
Radiologically, I wouldn't completely rule out MOG.
Okay.
But is it response appropriate for the medication given, and correlate that? That was the question, I think. Possibility of Paul G or Melas. Melas is possible. Paul G, maybe, but thalamus is usually involved. That was slightly stroke-like symptoms.
No, sir. We also did lactate, which was normal, even despite having status.
Any other suggestions? I've just shared a few of our cases of MOG cortical encephalitis, restricted diffusion is seen. So, any follow-up imaging after this to see if
No,
the
sir.
edema has progressed?
No, sir.
And no optic neuritis, no cord abnormalities.
Cord we have not scanned, sir. Optic neuritis is not there.
Okay. Yeah, I wouldn't completely rule out MOG though, just on imaging wise. Okay.
Status has resolved now. We are tapering the midazolam infusion.
Okay. Any other comments treatment wise? Any other things to be investigated? Okay. Okay, Ruchi. So imaging wise, at least I wouldn't rule out MOG as a possibility. I've shared few cases which have some almost similar appearance involving the cortex with diffusion changes. Mitochondrial, as you have said, less likely. Infection always, but yeah, the labs have found out to be negative. So MOG is still a possibility, according to me. Okay. All right. I don't think we have any other comments. So,
Yeah, Nihaal, just one.
yeah, Anish.
Yeah, I've seen a similar case in an adult in a case of SLE encephalitis. Any pointers towards that? Just throwing it out.
Okay.
Maybe the headache, maybe the head injury may just be a red herring.
No,
Any
sir.
thrombocytopenia, any anemia, anything to a systemic rheumatological pathology?
No, sir. Thrombocytopenia and anemia were not there, and 10-month-old male child. So.
Okay. Actually, I think we don't have anything else to add to it. What are you treating it as?
Currently, we are treating status only because even after giving ketamine infusion, seizures were persistent. So we have given methylprednisolone both for the benefit of weak MOG and status.
Yeah. Okay. Progressing into ALRD type pattern, maybe. Seizures are biphasic or resolved. Okay, it's fine. But yeah, I'll share few references of MOG particular variants. Maybe you can have a look. So. Okay. If no comments, then yeah. Thereafter. All right. I think that's the last case. So no consensus, but not ruling out MOG. Just to conclude.
Yes, sir.
Thank you. And that should be our last case. Yeah, thanks again. I think pretty complex set of cases as usual. So we'll meet again in a couple of weeks' time. Till then, bye-bye. Have a good night. Thanks, Rajkumar. You can end the session.